Good afternoon and good morning to all of you joining for our webinar today. This is Angela Tobin, and I am on staff at Alliance Chicago, helping to oversee our health center controlled network. And we are in partnership with the Illinois Primary Healthcare Association, who will be delivering the content for today's webinar, which is focused on UDS 101 and 2021 clinical reporting changes. This webinar is being recorded and we will make it available along with the slide deck to you after this session today. We welcome any questions at any time that you would like to pose in the chat box. We ask that you please mute your lines when you're not talking, and we will have time for questions and answers during this session, so you can either ask them verbally or you could put them in the chat, and we will try to get through all of them today. So with that, I will hand it over to our speaker today, Nyla from the IPHCA.
Thank you so much, Angela. I am not able to see the slides. I don't know if you are sharing them.
Oh, I am sharing them.
Okay.
Does anyone else see them?
No, we can't see them yet.
Oh, shucks. Thank you. Let me work on that. One moment, please.
Thank you. Perfect. I see them now.
Wonderful. Thank you. Okay, go ahead.
Thanks. So good morning or good afternoon, depending on where you are, everyone. My name is Nyla Husney. I'm the Senior Manager of Clinical Quality Improvement at the Illinois Primary Healthcare Association. So for today's office hour, I'm happy to be joining the Alliance Chicago team to be doing an overview of UDS 101, as well as the 2021 clinical reporting changes for those who are new to UDS or just beginning the reporting process for this year, and also just to serve as a refresher for those who are already familiar with it. So at the end, we'll have plenty of time for Q&A, and if anyone wants to share any of your best practices or tips as well, that'll be a great time for that. So I'll go ahead and get started. Next slide, please. So these are our objectives. Again, I'll just do a general introduction to UDS, a brief overview of the clinical indicators, and then go over the 2021 reporting changes for the clinical indicators. And then again, time for Q&A and sharing. Next slide. So starting with UDS 101. So just an overview for those of you who are really new to the health center world and the reporting process. UDS stands for Uniform Data System, and these are the standardized set of data reported by health centers each year to HRSA. It includes information regarding patient demographics, health center services provided, clinical processes, health outcomes, staffing, patient use of services, costs and revenue of documenting operations. This data is all reported in your electronic handbook or your EHB, as according to the UDS manual requirements that are updated annually. And so within the EHB, you'll have a number of tables, including first you'll have contact information for your health center. You'll have the patients by zip codes table, and that's really for compiling national and state data and to identify any service gaps. And then you'll have table 3A, which collects age and gender information. Table 3B collects demographic information. Table 4 collects data on selected characteristics of patients such as income level and special populations information. Table 5 includes profile of health center staff, number of visits, number of patients served in each service category. Table 6A includes clinical data, including selected diagnoses and services. Table 6B and 7 capture the core set of clinical quality measures. So those are established by CMS, and those are what we'll be kind of getting into a little bit today with regards to the major changes. And then those clinical information that you report to HRSA also help to track national initiatives, prevent health issues, and really see where the gaps are. And then Table 8A collects dollar amounts for medical costs and costs of clinical services. Table 9D gathers information on charges, collections, supplements, self-pay sliding scale discounts. And then Table 9E, reports on dollar amounts of patient income received during the reporting period. And then you have dependencies, which includes information on health IT and other data elements. So all of this will be included in the different in the UDS manual, as well as the different resources, which I'll present later on in the presentation. So next slide, please. So with regards to reporting dates, health centers report UDS data every year between January 1st and February 15th. The data that is reported covers the prior year. So this year you'll be reporting on the 2021 data, of course. After the reporting window closes on February 15th, that data is reviewed and finalized by March 31st. The data is analyzed on an individual health center or health center lookalike level, at a state level, and at a national level. And then once all the changes have been made, no changes can be made after March 31st. And then some tips to keep in mind: all of the tables are interrelated, so make sure you are communicating with your teams, across your teams, as you're preparing this data. Review data across the tables to ensure that it's consistent. Review any changes in performances to make sure that that data is accurate and that you're identifying any potential quality improvement initiatives. There's also many tools that HRSA has available that are helpful for this with their modernized reporting features. Now there's Excel files, offline HTML files, comparison tools, Excel mapping documents, and those resources will be included in my final slides. And then just make sure that you're checking your data for accuracy. Work with your EHR vendors to ensure the data output is accurate, and verify that the calendar year updates have been programmed. Check your data trends across the table and make sure that it looks accurate and reasonable. And you can also use the data comparison tool to compare it with previous year trends as well. Next slide, please. So now I'll be doing an overview of the clinical measures. So the first thing to remember when reporting your clinical quality measures is to make sure you're following all the definitions and instructions in the 2021 UDS manual. I'll be going through some of the most commonly used definitions in the next few slides, just so you're familiar with those. Make sure you're quantifying your care provided during that measurement period. Make sure you're reporting on all UDS listed clinical quality measures if the denominator criteria are being met. And then make sure you're evaluating patients who had at least one countable medical visit during the year. And then for the dental seal measure, it would be the dental visits for that year. Next slide, please. So I just wanted to go through some of the definitions that you'll be seeing while working with the UDS data and the reporting, specifically for the clinical measures, just so you're familiar with these. The first one being the UDS clinical quality measures, or CQM, and this is the process and outcome measures tracked and reported by your health center, required by HRSA, and they include the 15 quality of care measures reported in Table 6B, and then the 3 health outcome and disparities measures reported on Table 7. ECQM, which stands for Electronic Specified Clinical Quality Measures, are the standardized tools that help measure and track the quality of healthcare services that your eligible professionals and other health center organizations provide within the EHR. A measure steward is an individual or organization that owns a measure and is responsible for maintaining that measure. So each ECQM does have a measure steward. Your measurement period represents the calendar year, this year 2021, unless another time frame is specifically noted. And then your look back period is a measurement period that requires data for some length of time prior to the reporting period. Next slide. And then your measure description are the quantifiable indicators that are being evaluated. The denominator, of course, is the patients who fit the detailed criteria described for inclusion in the specified measure to be evaluated. Your numerator comes from the records from the denominator, or records from the denominator the number of patients that meet that criteria for that specified measure. Exclusions are patients not to be considered for the measure or included in the denominator. Exceptions are those patients removed from the denominator because the numerator criteria are not being met. Specification guidance includes the CMS measure guidance that assists with understanding and implementing CQMs. And then the UDS reporting considerations are additional HRSA requirements or guidance that are to be applied to the specific measure, and they could differ from or expand on the ECQM specifications. So again, those are just some definitions to consider and remember while doing the reporting process. And now I just wanted to go over the different clinical quality measures. These can be grouped in 3 categories. So the first one being the screening and preventative care measures. So we have on table 6, we have cervical cancer screening, breast cancer screening, adult body mass index or BMI screening and follow-up plan, tobacco use screening and cessation intervention, colorectal cancer screening, HIV screening, and screening for depression and follow-up. So we have marked here cervical cancer screening and the tobacco use screening cessation intervention, as those are the 2 with major changes in the 2021 year, and I'll be going more into detail with those 2 in the upcoming slides. And then I also just wanted to point out that breast cancer screening and HIV screening were new measures in 2020. So HIV screening looks at the percentage of patients 15 through 65 who are tested for HIV within that age range, and then breast cancer screening looked at the percentage of women 51 through 73 who had a mammogram to screen for breast cancer. Next slide, please. And then we have the maternal care and children health measures. So these go across table 6B and table 7. On table 6B, we have the prenatal care provided by referral only, age of prenatal care patients, early entry into prenatal care, childhood immunization status, the weight assessment and counseling and nutrition and physical activity for children and adolescents, and dental sealants for children between 6 and 9. And then table 7, we have HIV positive pregnant patients, deliveries performed by the health center's providers, prenatal care patients who delivered during the year, and low birth weight. And then the final set of clinical measures on the next slide will be the chronic disease management measures. And these again go across table 6B and table 7. Looking at statin therapy for the prevention and treatment of cardiovascular disease, IBD use of aspirin or another antiplatelet, HIV linkage to care, depression remission at 12 months, controlling high blood pressure, and then the diabetes, looking at A1C poor control, which is over 9%. So again, I just wanted to point out a new measure in 2020, which was the depression remission at 12 months. This looks at the percentage of patients 12 years of age and older with depression remission or dysthymia who reached a remission 12 months after an index event. So those are the clinical measures you will be looking at while doing the reporting process. Next slide, please. And then now going into the 2021 clinical reporting changes. The first notification that you'll receive from HRSA on the changes for the upcoming year comes from the Program Assistance Letter, or the PAL. This provides an overview of updates to the 2021 UDS, and the intent is to summarize and explain items of significance for health centers, including HRSA program implementation activities, any recently enacted laws, final regulations, or any HHS initiatives. So I have linked it here, and if you've downloaded the slides, you can access the link for the PAL for 2021. And then all the additional details regarding those updates are, of course, outlined within the 2021 UDS manual. Next slide, please. So the first set of changes that come from the Program Assistance Letter are the update to the quality of care measures to align with the ECQMs for Table 6B and 7. So in order to support efforts across federal agencies that standardize data collection and reduce reporting burden for those who are participating in these programs, these UDS clinical quality measures that have been listed here have been aligned in order to have been changed in order to align with the versions of CMS's ECQMs that are designated for the 2021 reporting period. And the reason being that the data-driven quality improvement and full optimization of the EHR systems are strategic priorities for HRSA. So clinical measurement alliance across all the national programs helps to decrease the reporting burden for your part, and of course, improve data standardization. And so these also help to be aligned with other national quality programs such as the National Quality Forum, CMS's QPP. And then here in this table, we've also included hyperlinks to the ECQMs, so you can look at further detail for each of those. Next slide, please. So now the major changes, the first one being for Table 6A. So back in 2020, in response to COVID-19, the 2020 UDS included COVID CPT and ICD-10 codes to enable the collection of COVID testing and treatment data at the health centers. So these codes are also included in the 2021 UDS reporting. As you can see, in order to continue informing HRSA and HHS about the health center's COVID testing and treatment capabilities. So the new line here in Table 6A is 24B, and this is for the COVID vaccine. So column A under 24B, you'll be collecting the number of visits at which the COVID vaccine was administered to health center patients, and then column B will be the number of patients who have had one or more visits where the COVID vaccine was administered. This was removed from Appendix E, sorry, which is where you reported it in 2020, and it will be in Table 6A now in 2021. Next slide, please. And then the major changes, so there were two major revisions in the clinical measures this year. The first one being in Table 6B, tobacco use screening and cessation intervention. So the main revision was that HRSA revised the time frame for the numerator from 24 to 12 months. As you can see, the comparison between 2020 and 21, that 24 months changed to 12 months. They revised the timing associated with performing a tobacco cessation intervention in the numerator. They also removed the constraint that the intervention occur after the most recent tobacco use screening, during which the patient was identified as a tobacco user, and ties those actions to the measurement period. This was changed in order to reflect the revised clinical guidance and expert feedback, which were incorporated into the measure steward. Next slide, please. So just some further clarifications. Again, documentation of medical reasons for not screening for tobacco use or for not providing tobacco cessation intervention, for example, for medical reasons, must be documented by the provider at the visit. Include in the numerator the patients with the negative screening and patients with the positive screening who had cessation intervention if they're a tobacco user. If the tobacco use status of a patient is unknown, the patient doesn't meet the screening component and hasn't met the criteria in order to be counted in the numerator. If it is unknown, then include the patients who are not screened or patients with indefinite answers. And then the electronic nicotine delivery systems, which include electronic cigarettes, are not currently classified as tobacco and are not included in this measure. And then cessation counseling intervention for a tobacco user must occur at the or following the most recent screening and before the end of the calendar year. So just a reminder, if the person had multiple screenings, use the most recent screening that documents the status as a tobacco user or non-user. Next slide, please. And then the next set of major changes on Table 6B was the cervical cancer screening measure. Here you can see from 2020 to 2021, the numerator was revised to align with the updated clinical recommendations. And for patients aged 30 years and older, it permits the HPV testing alone every 5 years. So this was updated in order to remove that cytology and co-testing for women aged 30 to 64 and replace the term every within the last. Again, this aligns with the U.S. Preventative Services Task Force updated guidelines, which were updated in 2018. So again, the first part was not changed, but the second bullet here in 2021 is where you see the slight change occur. Next slide, please. And then some clarifications for this. Here we've included the exclusions, which are women who had a hysterectomy with no residual cervix or congenital absence of cervix, and then women who were in hospice care during the measurement period. Just a reminder, cervical cytology HPV testing are not acceptable via telehealth, so those services cannot be conducted via telehealth. And then make sure you're including patients of all genders who have a cervix for the measurement assessment. Next slide, please. And then all the remaining changes to the 2021 UDS financial and operational tables will be addressed in our PCA UDS training. The HRSA reviewer actually addresses these questions and changes themselves, as at that time they'll come to final decisions on reporting for those tables and could get into more specifics regarding those for the financial and operational tables. And if you have any questions at that time. So I do want to put a plug in here that our IPHCA HRSA training will be December 1st, 7th for the 3-hour trainings. And then our Q&A session will be on December 8th. And then from IPHCA, our registration will be coming in the next few weeks. And if you are from a different state, please make sure to check with your state PCA for your training dates or the HRSA training website. And I know the Alliance Chicago also has upcoming webinars where they'll be going into a deeper dive with tables 6 and 7 as well. Really today, I just wanted to go over a brief overview for those who may be new to UDS. So please look out for those TA webinars coming soon as well. And then the last slide goes over the resources. So of course, first you'll want to start with the UDS 2021 manual. It really has all the guidance and instructions. So becoming familiar with that will be the best first step to starting your reporting process. We've included here the ECQI Resource Center for all the ECQMs. And then we have linked the telehealth impacts on clinical measures resource. There's a clinical measures handout that goes through all the clinical measures, including all the numerator and denominators and the major changes in that handout. And then the ECQM flows has the zip file of all the workflows for each indicator, which I know was gone over in the last webinar as well. And then we have the guide for reading ECQM's resource, the latest updated version for that. And then we have the telehealth resource as it relates to the UDS clinical measure reporting. We have the CMS telehealth guidance for ECQMs linked here. And then the final list of resources includes all of the resources linked to reporting, including 6A, including table 6A codes that were mentioned earlier, and then all the UDS trainings that came from HRSA, including their webinars that are recorded and linked within that resource. And that is all from me today. On the next slide, I just want to say thank you. And if anyone has any questions or would like to share any comments, now would be the time. So thank you.
Thank you so much, Nyla. That was fantastic. Very well organized and clear. And the slide deck is going to be shared after this call along with the recording. So much appreciated for how everything was laid out. And like Nyla said, we welcome any questions at this time. You can either put it in the chat or unmute your line and ask the question. Yes, we will be sending via email to all of you who have registered a link to the recording as well as the slide deck that will have those embedded links for resources.
And if anyone would like to register for the upcoming IPHCA HRSA training, please reach out to me. And once I have that registration information, I'll be sure to share it. I've included my email address here too, if any questions come up after the webinar.
That's great, Nyla. Thank you. And yes, and thank you for mentioning also, we had this webinar today. This past Wednesday, we had a webinar that looked at clinical workflows. And then upcoming in November, we will have a date later today to share with everyone, but in mid-November will be our next UDS support webinar sponsored by the PTech network. And it's going to focus and drill down a bit more on those tables 6A, 6B, and 7 that Nyla had mentioned. But we're going to be looking at it in terms of how to generate reports that will get the information you need for your UDS. And we will be looking at examples via EHR as well. So we're not gonna get into specifics, but we will have at least some screenshots to show you what this looks like in different EMR platforms. I'm not seeing any questions come through in the chat. We'll just give it another minute or so if anyone has anything that they want to write or in the chat as a question, or if you'd like to speak a question at all. We're here to support any of your UDS reporting needs. We know that it can be a busy time to develop the reports, even though they are not due until February. We know that leaving it to the last minute can be very crazy on top of everything else that health centers are managing. So we want to help you prepare and feel as ready as possible so that scramble isn't as intense come February. Okay, well, seeing no questions come in, we will go ahead and end this webinar now so everyone can get back to their Friday schedules. Again, Nyla's email is right here if you have any questions for her, but we will also be sharing all the links to the recording and the slides and how you can contact us with any of your follow-up UDS questions. And with that, I hope everyone has a great rest of your day and you're looking forward to a good weekend. Take good care, everyone, and thanks again, Nyla, for your presentation today.
Thank you, Angela, and thank you, everyone.